Welcome to the Iferia TechCast, where we bring you all things science, engineering, technology, and innovation. I'm your host, Ezekiel Iferia, and today we are joined by Dr. Ivan Nadler. Dr. Nadler is a pediatric bariatric surgeon and a pioneering researcher in the field of childhood obesity with over 20 years of experience and NIH-funded studies on fat cell biology. He challenges the conventional calorie in, calorie out model, framing obesity as a complex disease with multiple biological pathways. He now runs a telemedicine practice and is writing a book to translate this science into accessible treatment strategies, aiming to transform care for both children and adults. In this episode, we'll explore his systematic biology first approach to understanding weight regulation and how technology is bridging gaps in specialized healthcare. So, Dr. Ivan, it's a pleasure to welcome you to the Feria TechCast. Thank you for joining us.
Thank you, Ezekiel. My pleasure.
Great to have you here. So let's dive in, Dr. Ivan. You have been treating childhood obesity for over 2 decades. So when you first started, the prevailing wisdom was calorie in, calorie out. So what was the first piece of evidence from your patients or your lab that made you question that simple equation?
That's a great question, Ezekiel. And when people sort of along the way, over the past 20 years have sort of been critical of what I do, I've always told them, just come to my clinic and see some of my patients because your point of view will change completely. And so you asked, what was it that sort of led me to understand that it's not just calories in, calories out. And it was the patients. It was the, let's say 10-year-olds fighting obesity who didn't eat any differently than their peers, and they didn't exercise any differently than their peers, other than maybe not being able to do some of the stuff they wanted to because of their weight. But they were basically having the same exact behavior as any other typical 10-year-old, yet they were struggling so severely with their weight. So it was pretty obvious that it couldn't just merely be calories in, calories out, because that wouldn't make sense. And I think in general, childhood obesity, if you think about it, these kids aren't even on the planet long enough for the calories in, calories out equation to work. So in retrospect, it was probably more obvious all along. It just never really, hit me in the head, or I didn't have that epiphany moment until I started seeing the same patients over and over again. And they weren't overeating and they weren't completely sedentary, yet they were still struggling with weight and its complications.
All right. So, Dr. Evan, you describe obesity as a disease with many internal pathways. So, can you give examples of patients who might look the same on the outside but have different biological source code causing their weight gain?
Yeah. So what many people don't necessarily know is that there's part of your brain called the hypothalamus, and the hypothalamus is the area that regulates both your hunger and your feeling of fullness, or what we call satiety. And there are things that can happen to you as a developing baby to your hypothalamus that changes your weight set point and may predispose you to obesity. But then there's actually stuff that can happen to you after you're born. So for instance, if you had a brain tumor in your hypothalamus that required a surgical resection or removal of part of your hypothalamus, you actually get obesity after that operation, even if you had no predisposition to it before the operation. So they're just different. And obviously that's a rarer example, but it just is meant to show you that there are definitive definitively different ways to obesity. And yes, it still looks the same to all of us on the outside. The different, for instance, that sort of patient who's had surgery to their hypothalamus, their treatment is very different than someone who has an intact hypothalamus. Like some of the medications and some of the other things just don't work if you don't have a hypothalamus. So you have to factor that into your treatment algorithm. So it's a complicated way of saying that just because it all looks the same on the outside doesn't mean it's all the same on the inside. And if you're going to try to provide best treatment, you really have to understand the inside piece to know how to treat it best.
All right, that was an interesting and insightful response. So, your research involves studying fat cells at a biological level. What's the most surprising thing you've learned about how an how fat cells actually functions? Like, how is it more than just a passive storage unit?
Yeah. So that's another great question because, again, most people think about fat cells as a storage unit for excess energy and then don't necessarily understand the pathophysiology between those fat cells being overfilled or reaching their storage capacity, and then how that translates to disease throughout the body. But basically, what happens is that once the fat cells exceed their storage capacity, they release factors into your bloodstream that can cause disease in your distant organs, liver, muscles, pancreas. And so the most surprising thing that I found in our studies were that we found that there's actually genetic material from these fat cells, microRNAs, that get released when the storage capacity is exceeded. And it's these microRNAs that can turn genes on and off in the distant organs. And they actually even cross the placenta and can cause cells in the developing fetus, developing baby, to differentiate to fat instead of muscle. And so that was a completely new pathway for obesity to, to happen, or it was a new pathway for the way that fat cells could impart action on distant organs. Because before our findings, everybody and most people still were focused on cytokines or cytokines, or basically different compounds that are released into the bloodstream that one can measure, which is why I think people have been focused on them. And so in our lab anyway, we found that these microRNAs are probably more important, maybe the most important way fat cells act, as opposed to the cytokines and adipokines.
Okay, thank you very much for that very insightful response. So, the concept of a body weight set point is fascinating. So, how does this biological thermostat work, and why does it make sustained weight loss so difficult from a purely physiological perspective?
Yeah. So we don't exactly know how the hypothalamus chooses your body weight set point, but it's likely in part genetics from what's passed on from your parents. And then we do know that babies who are in development and the mom has gestational diabetes or gains a lot of weight during pregnancy, that predisposes the hypothalamic set point to be higher, and might be actually how some of the ultra processed foods that everybody's focused on right now have an impact as well. And that's a field called epigenetics, which is how the external forces can change the way genes are expressed and function. But what ends up happening when you're, after you're born and you have your hypothalamic set point, your body tends to want to be at that weight, whatever that weight might be. And then studies have shown over the years that if you start to lose weight intentionally, that your body will slow down its metabolism so that it makes it harder to lose more weight, which was probably like a protective response that developed over years of trying to protect the body against malnutrition.
Mm,
So If you lose weight, your metabolism slows. So that makes losing more weight harder, but it also makes gaining weight easier. And similarly, there's studies that showed if you gain weight intentionally, and they used to do there were some studies that couldn't be carried out now because they're maybe not as ethical as one would like. But if you force people to gain weight, their metabolism actually speeds up. And once you stop forcing them to gain weight, their weight will drift back down to the
Wow.
weight separately. So now, again, the ultra processed foods after you're born may change your hypothalamic set point. They might make it so that the set point continues to go up. And that also might happen in utero if the mom is exposed to some ultra processed foods. We don't know that for sure, but that's possibly how the negative effects of those foods, or certain members of that food group, may cause problems for people. But it's a field where there's so much yet to learn, so much we still need to learn.
Mm.
So it's not clear or definitive in any way as of yet.
All right. So you are passionate about treating obesity early in childhood. So, from a biological standpoint, why is intervening at a young age so much effective than trying to resolve the disease later in life?
Yeah. So I like to make the comparison to how we used to talk about in medicine cigarette smoking, where it wasn't just how many packs per day you smoked, but it was for how many years. So we would talk about, a 20 pack year history of smoking, meaning smoking a pack per day for 20 years, because the effects of cigarette smoking were cumulative over time. And the same is true with obesity, where it's not just how much weight or excess weight you're carrying, but how long you've been carrying that excess weight that sort of determines how your liver or other parts of your body are going to be negatively affected. So we know that there are certain diseases that progress faster in children. Type 2 diabetes is one of them. And
Mm.
what's called metabolic dysfunction associated steatotic liver disease, which is a mouthful, but it's MASLD. That also proceeds faster in children. So there's really no benefit to waiting. And we also know that just standard diet and exercise don't really achieve much in children or in adults for that matter. So that's why I've been an advocate for the past 20 years of treating obesity at whatever age it's diagnosed, because the benefits, there are no benefits of waiting. The myths that, baby fat, the kid will grow out of it, those are just myths. And yes, there is some normal fat accumulation during normal stages of development in children, but what we're talking about is abnormal fat deposition or abnormal weight gain, not the normal weight gain that is seen in every kid as they grow up. So, yeah, there's really just no advantage to waiting. There's nothing positive to be achieved by waiting to treat the disease once it's established.
All right. Thank you very much for making that clear for our listeners. So, Dr. Evans, you know, there are new medications, like the GLP-1 agonists that have changed the conversation. So, how do these drugs work on biological mechanisms you study, and what does their sources tell us about where we've been wrong in the past?
Yeah. So, the GLP-1 agonists, well, the first one that achieved weight loss, really taught us a lot about the biological pathways that are involved. And then now they're what are called biagonists, and there's even a triagonist under development. So we're really learning more and more about the different pathways that are important in weight loss. And what it turns out is that these GLP-1 agonists actually, not only do they have beneficial effects that are directly related to the weight loss, but they also have beneficial effects in some of the organs, such as the heart, that are independent of weight loss. And so these GLP-1, glucagon-like peptide 1 receptors are located in your brain, they're located in your gut, they're located on your heart, your liver, and when stimulated, they do different things in the different organs. in the brain, people report something called food noise, which is drastically reduced when they're taking a GLP-1 agonist. And that means just sort of the constant chattering in your brain about food or thinking about food. It's different than hunger. It's sort of almost like just thinking about food when it's really not appropriate to be thinking about food because you're not hungry. But then in the heart and the liver, the GLP-1 stimulation has other sort of anti-inflammatory positive effects, or at least that's what we think the effects are in those other organs. So these medications have really changed a lot about not only how we understand the disease of obesity, but also how we treat it, because obviously now we have these medications that can achieve significant weight loss, although once you stop the medication, most of the weight does come back on in the majority of people.
Great. So, for the parents in our audience who are worried about their children's weight, what's one actionable evidence-based step they can take that goes beyond just focusing on diet and exercise?
Well, diet and exercise are still the sort of core treatment pieces or adjuncts to treatment. So when people would come into my office and they'd ask me, or I would see them for the first time, I would basically say to them, like, let's make one behavior change, because I'm not gonna ask you to change everything about your lifestyle, but let's pick one thing that you can achieve and that will provide health benefits. And so that one thing is always sugar sweetened beverages. So sugar in beverages is basically the worst form of sugar for you,
Mm-hmm.
because if you eat sugar, at least you're getting full from the process of eating and the signaling that goes on with chewing and all those other things. But when you drink, it's really just pure empty calories. And sugar is likely, or is, the worst of all the things that we consume in terms of metabolism and metabolic health and overall well-being. But beyond diet and exercise, the one thing I would tell parents is don't be afraid to have the conversation with your provider or even your kid. Obviously, you need to do it in a sensitive and compassionate way if you're talking to your kid, but ignoring the problem isn't going to help anyone. And it's not in your child's best interest to sort of avoid the topic because you're worried about making your kid upset or the family dynamic. And I guess that would be the other thing is to remind families that it is always a family affair. So if you have one kid who's struggling with their weight, the whole family needs to make changes, because it's not going to be successful if you just have the one child and say, no Coca-Cola for you, but we have 6 packs of Coke in the house and the other kids can have it. Like, that's not going to be a winning strategy. So the whole family has to have a commitment to making the health of the entire family better, because even the kids who are normal weight, they don't derive any benefit from drinking Coke. It's just not, it's not good for them. And if they feel like they have to, then you just got to tell them, okay, you can do that, but you got to do it out of the house, and you got to do it, when the one child who's struggling with their weight isn't around to see it, because it's just too hard for that one person who needs to make the changes if no one else in the family is making the same changes.
All right. So you also talk about the intergenerational transmission of obesity. So, does a mother's health and environment during pregnancy literally program her child's biology for weight regulation?
Yeah, exactly. So that's exactly what happens. So there are a couple of different ways that parents can pass on obesity to their kids. One is definitely from their genes, and there are certain genes that we've identified that predispose to obesity, and then lots of others that we don't exactly know how they play a part, but there are over 100 genes that have been identified that may be important for weight regulation. And so that's one piece. And obviously those genes come from both mom and dad.
Mm.
Now, mom and dad's genes can be, as I briefly mentioned before, they can be epigenetically modified, maybe from pollutants, maybe from forever chemicals, maybe from ultra processed foods, but they can definitely be changed. And those genetically or epigenetically changed genes can also be transmitted from parent to child. So one of the things I tell families, or I wish the message would get out more to families about, is that before you have a baby, you really should be thinking about optimizing you and your partner's metabolic health, because that is probably the most important way that you can help protect your child from having a risk of obesity themselves. And then, as we talked about earlier, when mom is pregnant, the in utero environment is critically important. And we know that not only is it critically important for obesity, but there was a recent study that showed that moms who developed gestational diabetes or had diabetes before they got pregnant had I believe it was a 20% higher risk of having a child with autism. So it's not just for obesity, but it's for brain development as well. And there's another study that showed that the first 1,000 days post-conception, so that's basically a year inside of mom and then 2 years after birth, that sugar exposure during those times was intimately linked to diabetes risk in the child. So again, for me, it was probably more important in utero than in the first 2 years of life. But sugar is truly like the number one bad actor. So yeah, if people can optimize their health before they get pregnant, both mom and dad, and then mom pays a lot of attention to her health during pregnancy, that's going to be the most effective strategy for curbing the childhood obesity epidemic, and frankly, the adult obesity epidemic too, because once the kids grow up and they'll grow up with a better chance to be healthy adults. And actually, if mom and dad have already made a lot of health changes before the kid's born, then that child's born into an environment or a social situation with their family where everybody's already sort of in tune with better healthy habits. So I think that's, to me, the strategy that's likely to be the most effective long term. It's going to take a while, but that's what I would recommend for folks.
Great. So, looking at the future, like what emerging technology or research area, whether in genomics, digital health, or something else, are you most excited about for truly personalizing obesity treatment?
Yeah, that's a really interesting and complicated question. I do think we need to get a better understanding of personalized medicine. So not everyone gets genetic testing, obviously, but there can probably be some predicted models of figuring out who's at highest risk for obesity, including like family history of obesity and other factors, maybe economic, maybe geographic, maybe even local in terms of, again, air pollutants and things like that. I think personalized medicine is really important, and I think we do need to get a better understanding of that. I do think the new anti-obesity drugs are getting better and better, and will be more and more available and cheaper. But I also like, you mentioned the digital space, and I do think the medical world is probably moving towards AI assisted care, where complicated problems, children with obesity with complicated problems, they may not have access to specialized care. Like right now, there aren't enough pediatric trained obesity specialists out there. And that's one of the reasons I started my telemedicine practice, was to increase access to care. But another way that access to care will be improved is if we empower, local pediatricians or local primary caregivers with some AI assistance of some sort, so that they can actually provide, maybe they won't be able to provide the same level of specialty care, but they'll be able to provide more specialized care. So that excites me too. I think obviously everybody's talking about AI right now anyway, but I do think that that's going to be an interesting development in the future, and one that I'm certainly going to keep an eye on.
All right. Tell us, in your work from the lab to the operating room to the telemedicine screen, so what does true innovation in treating obesity really mean to you?
Well, when I first started doing bariatric surgery on children 20 years ago, innovation meant basically believing in the science and in myself and in a treatment option that no one else was willing to use on children. So it was a lot of just sort of confidence and courage of my conviction and really just moving forward despite what all the, haters and trolls and whatever, words that we use today that we didn't use 20 years ago. It was really, that was innovation to me back then, was really just doing things differently despite the conventional wisdom. And similarly now with the telemedicine, we started the country's first pediatric telemedicine weight management practice. And I'm sure there are people out there who don't think that can be done or don't think it's the right thing for children. But again, I have to believe that, expanding access to care, if it's well medically supervised, that it can be done via Zoom calls or Google Meet or whatever, just as well as with in-person visits. And that saves time for people, saves money for families, and makes care more accessible in general. But I think the biggest innovation for childhood obesity will be just people realizing that it's a disease and not a lifestyle choice, and that it's a disease worth treating and treating aggressively from a young age, depending on the individual patient. And that's the message I hope to get out there. And that's the message that if we can get out there, will truly change the care of children with obesity more than any other innovation that I can think of.
All right, Dr. Evans. Finally, for our listeners who want to understand this complex disease better, so whether for themselves or for their families, where is the best place for them to go start? Is it your upcoming book, your channel, or your clinical practice?
Yeah, so I would say, my website or my website, which is www.obesityexplained.com, or my YouTube channel, which is at Obesity Explained, or you can always email me at evan.nadler@epnmd, which are my initials, .com. Because I'm always happy to take questions from people and try to help people out. But start with the website or the YouTube channel. I do need more subscribers on the YouTube channel. That's always a good thing. Hit me up there.
All right. It's been a really insightful and educating conversation with you today. And I am very excited and honored to have you on the show.
My pleasure. Happy to come back, especially when the book comes out, which will be about a year maybe. I'll be
Yeah,
living again. So
I look
thank you.
forward to it.
Yeah, hopefully
Right.